Good afternoon and welcome to Cancer Conversations. My name is Jennifer Potter and I'll be your moderator today. Before we get started, I want to call your attention to the email address on your screen. That is for any questions that come up while you're watching our presenter today. We'll have time at the end to answer your questions about ovarian cancer and the material that's presented today, so I encourage you to make use of that. Today we're going to be talking about ovarian cancer, and we are delighted to have Dr. Vicki Bae-Jump with us. She's here at UNC. She's a researcher, a professor, and a physician who specializes in gynecological cancers like ovarian cancer. She's highly respected in her field and focuses on innovative new treatments for the disease. So without further ado, I'll turn it over to Dr. Bae-Jump.
Well, thank you very much. I'm very excited to be here to talk about ovarian cancer, and I kind of gave my title here, Where We Are, and then Where We Are Going, to give a little bit of information about sort of where the field is headed. So first, I wanted to just introduce our division of GYN oncology here at UNC. So I actually am one of 11 partners, and we are actually currently hiring partner number 12. But this is a composite of all of my partners here at UNC. We actually practice across 3 sites. So we practice here at UNC in Chapel Hill, also at Moses Cone in Greensboro, as well as UNC Rex in Raleigh. So I actually wanted to start this talk off with actually a patient story of one of my own patients, and this is Gail right here. And Gail actually was one of the very first patients that I helped take care of at UNC, and she actually documented her whole journey through cancer treatment through pictures, and actually very lovingly shared those pictures with me so that I could share with other patients and other families, etc., to kind of spread the word about ovarian cancer. So this is actually Gail, a picture of her right before her surgery with me for ovarian cancer. So Gail, when I met her initially, she was 47 years old, married, and the mother of 2 adult children, and she was from Roanoke Rapids, North Carolina, where she practiced as a real estate agent. When Gail presented to UNC, she reported a 4-month history of terrible constipation and stomach bloating. She had been to her primary care doctor many times, had many remedies for this, but just wasn't getting better. So her primary care doctor actually ordered a CT scan to see what else could be going on. And basically that CT scan was very concerning for a cancer that had spread throughout her abdomen and pelvis. Gail actually was very good about taking care of herself. She was up to date on mammograms, colonoscopies. She actually had a strong family history of colon cancer, had started colonoscopies at a very young age, as well as pelvic exams, as well as pap smears. Interestingly, she was referred initially to the surgical oncology clinic at UNC because they were concerned that this was colon cancer given her family history. But the surgical oncologist at that clinic actually looked at the imaging and really thought it was more concerning for ovarian cancer. So they got on the phone, they called me, and they asked me if I could see her right away because she was quite miserable. She had quite diffuse disease in her abdomen, and with the cancer cells in the abdomen, they can make a fluid in the abdomen called ascites that can make it very difficult to breathe and to eat and all of that good stuff. So she came over and I agreed that her imaging looked very concerning for an advanced ovarian cancer. So Gail went on to have surgery next, and she had a pretty extensive surgery. She had removal of her uterus, both tubes and ovaries. She had masses on both of her ovaries. She actually also had resection of part of her bowel with me because the cancer was actually very stuck to her bowel. And then we moved many other tumor nodules to really get as much disease out as possible. This was followed by 6 cycles of chemotherapy, which took about 6 months. And at the end of treatment, the good news is that Gail really looked like she had a complete response to treatment. Her pelvic exam was completely normal. She was having no more symptoms. And we also did a CT scan at the end of treatment that showed that there was no evidence of any cancer left. And I have taken care of Gail now for 15 years, and her cancer has not come back, which is the great news. Gail has gone on to welcome many grandchildren into the world. This is her, though this picture is a few years old, it's her with 3 of her grandchildren. She actually actively participates in Relay for Life in Roanoke Rapids, where she's from. Relay for Life is like kind of a walk-run that's done every year for all cancers. So the one thing to note is Gail's story definitely had a happy ending, but I wish that all of our ovarian cancer patients had happy endings like this, but actually only about a quarter of ovarian cancer patients actually have Gail's story, where their cancer goes into complete remission and never comes back. The majority of women, unfortunately, with ovarian cancer often have a recurrence, about 75%, and then it's very difficult to get the disease to go away again. Oops, sorry. So just wanted to go over kind of a little anatomy lesson to remind everybody what our reproductive organs look like. So in the middle, I think I have a pointer. So in the middle is the uterus. This is where actually where our babies grow, etc., are in this uterus, and then the opening of the uterus is the cervix. And so when babies are born, they come out the cervix into the vagina. Of course, when we have our menstrual flow or our periods every month, it's the lining of the uterus that sheds that also comes out through the vagina. And then we have two fallopian tubes shown here, one on each side, and then we have two ovaries. And the ovaries are what actually produces our eggs, and every month when we ovulate, the egg is released into the fallopian tube that then goes into the uterus. And then if it meets a sperm there, a baby can grow. Oh, sorry. Let me go back. Oh, sorry, went too fast. Okay. And so, in this slide, there is one normal ovary here, and then this is another ovary which shows a beginning of a cancer there. So just some facts about ovarian cancer. So every year, about 21,000 women will be diagnosed with ovarian cancer in the United States, and 14,000 women will actually die of this disease. Unfortunately for ovarian cancer, at the time of diagnosis, the vast majority of women present with advanced stage disease, which means that the disease has spread from the ovary to other places in the abdomen, which is exactly how Gail presented. So about 75% of patients at the time of diagnosis actually do have advanced stage disease, or what we call stage 3 or 4 disease. And in a later slide, we'll kind of talk about what the different stages are. The reason why we catch ovarian cancer so late is really due to the fact that we don't have a good method of early detection, and we're going to also talk about that a little bit later in the talk. So because we detect ovarian cancer at such an advanced stage, the overall 5-year survival of ovarian cancer is not very good. It's only about 30 to 50%. And what this means is that for all the women diagnosed with advanced stage ovarian cancer, 5 years after that diagnosis, only 30 to 50% of those women are still with us, which is not very good. So lots more research needs to be done for ovarian cancer. I also like to point out this fact that ovarian cancer is not as common as breast cancer, but actually 3 times more lethal. And this slide kind of brings home that point of how ovarian cancer is definitely rare but very lethal. So on the top part of this slide are the estimated number of new cancer cases predicted for 2020. And as you can see here, I'm like very fidgety with this. Okay, hold on. Sorry, I can't touch the mouse. So at the top part, these are the estimated new cancer diagnoses that are expected in 2020. And so as you can see here, ovarian cancer is not on this list, and then breast cancer, of course, at the very top. But the bottom part of this slide, you can see that these are the estimated deaths due to cancer predicted for 2020. And actually, ovarian cancer is on this list, and it's actually number 5. So ovarian cancer is a very lethal cancer. So these are some more ovarian cancer facts. The average age at diagnosis is 63 years old. So ovarian cancer usually occurs in older postmenopausal women. The actual risk is 1 in 80 women will be diagnosed with ovarian cancer. And just for comparison, for breast cancer, it's actually 1 in 8 women. The risk of ovarian cancer does increase if you have a first-degree relative with ovarian cancer. So this would be someone like your mom or your sister. So what causes ovarian cancer? Well, we actually really don't know all the different reasons why ovarian cancer develops. We're going to talk about some risk factors for ovarian cancer, but the cause is a little bit unknown. But in general, I put up here a kind of a description of why we think cancer occurs in general. So cancer develops when cells in whatever organ in our body develop errors or mutations in its DNA. And our DNA is sort of kind of our, basically our sort of underlying biology of how we grow and metabolize food and all of that good stuff. So when these mutations happen, they tell the cell to grow and multiply quickly. And because of this, the cells then grow into a mass. And then what happens next is abnormal cells from this mass then invade nearby tissues. So for an ovarian cancer, that would be the fallopian tube and the uterus. And then eventually, if the cancer continues to grow, those abnormal cells may break off and spread elsewhere in the body. They can spread through the bloodstream or through the lymph node system, and we can call this metastasis. And these abnormal cells, that's how they can reach places like the liver or the lung, very distant from where they started. So on this slide, I put some of the risk factors associated with ovarian cancer, as well as things that we know decrease your risk of developing ovarian cancer. So things that increase your risk are definitely getting older. That's a risk factor for any cancer, is usually getting older. Being overweight or obese is a little bit associated with ovarian cancer. One of the theories of why we think ovarian cancer develops is due to what we call chronic ovulation, which is when we actually produce that egg every month and release that egg. That's thought to maybe cause a little bit of trauma to the ovary. And then all of that trauma may increase our risk of developing ovarian cancer. And the way I think about this then is, according to risk factors, is anything that decreases the number of times we ovulate during our lifetime will actually decrease our risk of developing ovarian cancer. Whereas anything that increases the number of times we ovulate during our lifetime will increase our risk of developing ovarian cancer. So this would be things as having children later or never having children. So our body never takes a break from ovulation, like when we're pregnant. Also, having a family history of breast, colon, or ovarian cancer can also increase our risk of developing ovarian cancer, because we know some of these cancers can run together in families. Ovarian cancer is also associated with some genetic syndromes. About 15% of ovarian cancer overall is associated with genetic syndromes. And at the top of this list are actually the BRCA1 and BRCA2 high-risk mutations. And these, and women who carry these mutations are both at an increased risk of developing ovarian cancer as well as breast cancer. And these BRCA1 and BRCA2 basically stands for breast cancer-related genes 1 and 2. And actually the most famous BRCA1 carrier is actually Angelina Jolie, who's in the news quite a bit. So things that can reduce your risk are, once again, many times the things that reduce the number of times we ovulate or release eggs over our lifetime. So this would be pregnancy, where we take a break from ovulation. This would also be breastfeeding. We take a break from ovulation. And then also birth control pills, which actually suppress ovulation. That's how they work. And then other things are tubal ligation or hysterectomy, even if we leave the ovaries in place. We're not exactly sure how that works, but those things have also been associated with decreased risk. So just a little bit about the BRCA1 and BRCA2 genes. So for BRCA1 carriers, and for BRCA1 and BRCA2 carriers, they're at an increased risk of developing both breast cancer and ovarian cancer, though the risk differs a little bit according to what gene runs in the family. So for BRCA1 carriers, they have a 55 to 70% risk of developing breast cancer by the age of 70, and then a 40 to 45 risk of developing ovarian cancer. For BRCA2 carriers, the risk is a little bit less, but definitely very significant, a 45 to 50% risk of developing breast cancer and a 15 to 20% risk of developing ovarian cancer. So when we know that women carry these genes, there are actually things that we do to protect them from developing breast and ovarian cancer. So the first is actually to start breast and ovarian cancer screening at a very young age. So we start actually breast cancer screening with mammogram and breast MRI starting at about 25 years old. And then for ovarian cancer screening, we start at 30 years old. Now, I will say that we don't have great methods of ovarian cancer screening, but we use some things that we think at least can be a little bit helpful. Prophylactic bilateral mastectomy, or removal of both of the breasts, is also something that's offered to women. This can dramatically decrease their risk of developing breast cancer by actually 90%. But we actually do have good screening for breast cancer, so sometimes women choose just to be continually screened. And then for ovarian cancer risk, we can remove both fallopian tubes and ovaries, and this decreases the risk of ovarian cancer for these women by 80 to 90%. And we usually try to do this between the age of 35 and 40, so before the risk really starts for developing ovarian cancer. And wait, also though, we want to make sure that we wait until women are done childbearing. So what are the signs and symptoms of ovarian cancer? Well, they include things like upset stomach, feeling full quickly, stomach bloating, frequent urination, pelvic or abdominal pain, and other things like unexplained weight loss, pain in the pelvic area, and changes in bowel habits such as constipation. Ovarian cancer is often thought of as the silent killer, and this is because these symptoms are actually fairly vague, right? Who doesn't have an upset stomach or stomach bloating from time to time? But the important thing is if these symptoms are getting worse or persisting, and usually my timeline is 2 weeks, that I feel like it's something that you need to talk to your doctor about. I think that one of the reasons why, once again, it's called the silent killer is because these are symptoms that we as women can often ignore. We just think that we're getting older, but also our doctors can also maybe not be thinking ovarian cancer when they think of these symptoms. So I always like to make sure that everybody kind of put on here some guidelines of when you should see your doctor. So anytime the symptoms and signs that we talked about worry you, particularly if they persist for greater than 2 weeks, I do think it bears a conversation with your doctor. And then I think we should be proactive about our health care as women, and we should ask our doctor, should we be worried about ovarian cancer? And should we do something like an ultrasound to take a look at my ovaries? And then if you have a family history of breast and ovarian cancer, I think it's really important to once again talk to your doctor about it, because there are a number of genes, as we already talked about, that can be associated with these diseases that we can test for, and then we actually can do something about preventing these cancers. So are there any good screening tests to find an ovarian cancer early? Well, unfortunately, I wish I could say yes, but the answer at this point is no. We just don't have a good test or technique to find ovarian cancer early before symptoms start. And the reason why we want to look for cancers early is because we can find them before they spread, and then our treatments work so much better. So we have been definitely looking for ways to screen for ovarian cancer. One thing that's been looked at is the CA-125 blood test. So it's basically just drawn. This can be calculated just from your blood. The problem with the CA-125 blood test is it's actually increased in most women with advanced ovarian cancer, but actually not increased in every woman with early stage ovarian cancer. Actually, probably only about 50% will have an increase in the CA-125 blood test. So it's not very good at picking up those cancers early, which is really what we want. The other thing about CA-125 is it's not very specific, so it can be increased for a number of other reasons besides just ovarian cancer. So it can be increased for fibroids in the uterus, even a cyst on the ovary that's not cancer. It can even range during a woman's menstrual cycle from different stages in her menstrual cycle. So it's just not very specific. Pelvic ultrasound has also been looked at as a screening test for ovarian cancer. And pelvic ultrasound is really great at saying the ovaries are normal. However, when there's a cyst on the ovary or some sort of lesion on the ovary, it's not very good at telling us that it's an ovarian cancer. And so that's the hard thing, because when we ovulate every month, we actually do ovulate within a small cyst, and so it's not uncommon occasionally to see cysts, and ultrasound is just not good at telling us how much we should worry. So CA-125 and pelvic ultrasound have been looked at individually as tests to screen for ovarian cancer, as well as together, and unfortunately they're just not great at picking up ovarian cancer early. So, and then one thing just to reiterate, the reason why we want this early screening test is that when we catch ovarian cancer early, the 5-year survival rate is actually very, very good. It's about 93%. So when you think back to one of those first slides that I talked about, when we talked about advanced ovarian cancer and the overall survival being 30 to 50%, well, this is a really good overall survival. So women with early stage cancer, 93% of them are still with us 5 years after their diagnosis. But unfortunately for right now, only 15% of patients are diagnosed early, and most ovarian cancer patients are diagnosed with advanced stage disease. So the best that we can do now for ovarian cancer is actually to watch for these signs and symptoms: bloating, pelvic or stomach pain, difficulty eating or feeling full quickly, a feeling of needing to urinate or pee urgently or more often. And I highly encourage you that if you have these symptoms, to talk to your doctor and think about having a pelvic ultrasound. The chances are most likely when you have these symptoms, it's not going to be ovarian cancer, but at least when you get the pelvic ultrasound, hopefully it'll help rule this out better. So then how is ovarian cancer diagnosed? Well, it can be many different reasons. It can be on a pelvic exam, which is shown here, where we can actually feel the pelvis and feel to see if the ovaries are enlarged or if it's concerning. We can also do imaging tests to see if the ovaries are enlarged or we're worried about their size or what they look like. CT scan is another possibility once a woman is having symptoms and we're worried that this could be what's going on. Blood test CA-125 can also be helpful. Like I said, CA-125 is elevated in the majority of advanced stage cancers. But ultimately, usually ovarian cancer is diagnosed by surgery, and then if surgery is looking like it's not a good possibility for a patient, even like for example, if the disease is very, very diffuse and it doesn't look like surgery is the right step, then sometimes we'll do a biopsy of a mass in the pelvis to see if it rules in or out ovarian cancer. So this slide shows us the different stages of ovarian cancer. So they go from stage 1 to stage 4. So stage 1 cancer is a cancer that's confined to just one or both of the ovaries, but definitely just in the ovary. A stage 2 cancer is when the cancer has spread inside the pelvis to nearby structures, so things like the fallopian tube or the uterus. Stage 3 disease is when cancer is spread throughout the abdominal cavity. So, and usually the pattern is what we call carcinomatosis, or small nodules along the bowel and the lining of the abdomen and the fat of the bowel, or it can be spread through lymph nodes throughout the abdomen and pelvis. And actually, when we talked about Gail's story, this is kind of what her cancer looked like. And then finally, stage 4 cancers are when there's been spread beyond the abdomen. So this means actually cancer within the liver or cancer within the lungs. So how is ovarian cancer treated? Well, I usually think that there are 3 ways that we treat cancers in general. So there's surgery, there's chemotherapy, and there's radiation. For ovarian cancer, it's actually not very sensitive to radiation, so we don't use it often in the treatment of ovarian cancer, although we do use it in special cases. I've had cases where women have responded really well to surgery and chemotherapy, but maybe there's just one little lymph node that won't go away, and sometimes I'll radiate that, and that will make it go away. But typically the treatment is usually a combination of surgery and chemotherapy. The surgery is usually removal of both tubes and ovaries and the uterus. And then if the disease is very advanced, we try to remove as much of the cancer as we can, because we actually know that outcomes are better the more cancer that we remove. And we call that actually a debulking surgery. If a woman looks like she has an early stage cancer or cancer that's just confined to the ovary, we actually do what we call a staging procedure, where we actually look to see if there's microscopic evidence of that cancer spreading. So we once again still take out the other ovary and the uterus, but we'll actually take out lymph nodes surrounding the ovary, and we'll do biopsies in 6 different places in the abdomen and pelvis in order to figure out if there's any spread there. And then we also take out some fat along the bowel that's called the omentum. And a long time ago, we thought that we would be very good at figuring out if there was microscopic disease just by feeling or by imaging. And what we found out is that 30% of the time, even when I as a surgeon, and even when we had great CT scans and they were all negative, we still, when we took out those lymph nodes or did those biopsies, we actually found cancer about 30% of the time. And so we really need to do that staging procedure to really figure out if the cancer is spread or not. So surgery and chemotherapy are kind of our very 2 great treatments for ovarian cancer. Sometimes we do the surgery first, and sometimes we do the chemotherapy first. It actually really depends on what the disease looks like on imaging at the start of treatment. If it looks like we can go in and remove most of the cancer, even if it's advanced cancer, then we'd like to start with surgery if we can. However, there are times when we look and we know that we'll have to remove too much bowel, or if they're spread to the lungs, we can't remove those nodules. So sometimes we start with chemotherapy to shrink the disease and then ultimately go back for surgery. So chemotherapy for ovarian cancer is usually 2 types of drugs, taxanes and carboplatin. They're given once every 3 weeks. The infusion is given as an outpatient, 4 hours of treatment, and usually 6 cycles of treatment is about what we do for a typical initial diagnosis of ovarian cancer, depending on how people respond to treatment. These 2 drugs are fairly well tolerated, though of course all chemotherapy has side effects. And actually, when we do aggressive surgery and aggressive chemotherapy like this, the response rate is actually very, very good. So we'll actually have 75% of our ovarian cancer patients go into remission with this aggressive treatment. The problem is that these are not cure rates for women with advanced stage ovarian cancer. Despite the fact that we get 75% of women into remission with that aggressive surgery and chemotherapy, unfortunately 75% of those women will have their cancer come back in the next 5 years, with the next 2 years being the chance of the greatest risk. And then it'll be very difficult for them to go into remission again. And it's just, cancer is much, much more difficult to treat when it comes back. So definitely improvements or treatment are desperately needed, which is one of my areas of research as well. So on here I put kind of our great challenges for ovarian cancer. So how can we help prevent ovarian cancer? We know that oral contraceptions and breastfeeding can help reduce risk. It's always good to maintain a healthy weight, and then good to know your cancer family history. So if you are qualified for testing for some of those genes that are associated with ovarian and breast cancer, that you get that testing done. How can we find ovarian cancer earlier? Well, right now the best way to do it is to watch for signs and symptoms, but certainly that's not as good as some of the other screening methods we have. For example, mammogram for breast cancer, colonoscopy for colon cancer, and pap smears for cervical cancer. So we definitely need to find better ways. CA-125 and pelvic ultrasound are just some ways that we've tried to look for ovarian cancer early, but just haven't been very successful. But many, many people are trying to figure out some good tumor markers. I have a collaborator here at UNC where we're looking at potential markers for ovarian cancer actually in urine to potentially use as screening. And then how can we better treat ovarian cancer, especially when it comes back? So Taxol and carboplatin came into play about in the 1990s, so they actually haven't been with us only for about the past 20 years. Before Taxol and carboplatin, actually everyone just died of ovarian cancer. We had no good treatments. And so Taxol and carboplatin actually did really improve things for ovarian cancer. But unfortunately still, most women with ovarian cancer will have their cancer come back and not be cured of their disease. So we definitely need to think of better and better treatments. So one of the areas that's a great area of research for ovarian cancer, although for a number of different cancer, is actually targeted therapy for ovarian cancer, which is just kind of a different type of chemotherapy. But this type of cancer treatment uses drugs to find and attack cancer cells while actually doing little damage to normal cells. So actually this means they're actually a little bit better tolerated because they really go after the cancer cells. Each type of these target therapies can work differently because actually for different cancers there can be different pathways of how those cells grow and the metabolism of those cells that can be very different whether you have ovarian cancer or breast cancer or colon cancer. So it's really looking more closely at the cancer and what pathways are altered in that cancer to make it grow. And so there's quite a bit of work of trying some targeted therapies for different cancers. For ovarian cancer, is probably one of the greatest successes in targeted therapy is actually a class of drug called PARP inhibitors. And PARP inhibitors work against kind of the way our cells repair DNA damage. And actually we've found through quite a bit of research that PARP inhibitors are actually particularly effective in women that carry the BRCA1 and BRCA2 mutations, but actually are effective in many women with ovarian cancer, not just the BRCA1 and BRCA2 carriers. And so now actually for ovarian cancer treatment, most women after they've finished the aggressive surgery, the Taxol and carboplatin, actually will take a PARP inhibitor, which is an oral drug that you take every day, and that actually has been shown to help prevent ovarian cancer from coming back. So we've only had those drugs for a couple of years now. So I guess my conclusion is that progress is definitely being made. So we are coming up with some new drugs, but definitely more progress needs to be made. And so other things I always tell folks to do that can help prevent ovarian cancer, but prevent lots of cancers and lots of other diseases, is eat a healthy diet, fruits, nuts, fish, vegetables, whole grains, beans, and yogurt. Exercise 30 minutes or more, 5 to 7 days a week, and know your cancer family history and discuss this with your doctor. And then once again, just to remind everybody about the 4 primary symptoms of ovarian cancer: bloating, pelvic or abdominal pain, difficulty eating or feeling full too quickly, urinary urgency or frequency. And so if you have any of these symptoms for greater than 2 weeks, please talk to your doctor. And then I will take any questions. I have on here She Rocks, which is actually an organization that started in Wilmington, and there's actually now another another group of this organization actually now in the triad, but their focus is actually to increase ovarian cancer awareness and also donate to ovarian cancer research. So they are a great group, and you should look at their website with some more information about ovarian cancer.
Thank you so much, Dr. Bae-Jump. That was really helpful, and I know I learned a lot of new things. And judging by the number of questions I've gotten, our audience was very interested in what you had to say. So again, if you have any questions, please send them to the email address on your screen right now. And if you have a couple minutes, we'll do some questions now.
Oh yeah, of course. I'm going to take a sip of water. But
sure. Yes. So the first question that came in was, what is the difference between ovarian cancer and an ovarian cyst?
Okay. So definitely an ovarian cyst is a growth on the ovary. Actually, when we ovulate, we actually do form a little cyst where that egg forms, but actually those cysts can actually, who knows why, maybe changes in our hormones or whatnot, they can grow, and we can actually form fairly big cysts on our ovaries. Now the difference, I think, between kind of a benign, what we call a benign or a non-cancerous cyst on the ovary and a cancer is that a cyst on the ovary doesn't have the capacity to spread anywhere. And that's the biggest difference between a cancer on the ovary and a cyst on the ovary. Is the cancer on the ovary just has that ability for those cells to not just sit and form the cyst, but actually invade into nearby structures, get into the bloodstream, and learn how to travel. So I guess it's maybe just a much smarter version of that cyst. But the hard thing, like we talked about on the ultrasound, is sometimes ultrasound and other imaging is not great at telling us, is that just a big cyst on the ovary or is that a cancer? They can't always kind of tell kind of the behavior of it just by looking at it.
Yeah,
so hopefully that makes sense.
That does. Okay, our second question from the audience today is, does ovarian cancer treatment affect a woman's ability to have a baby?
So the hard thing about ovarian cancer treatment is that the first step in treatment is actually removing both tubes and ovaries. And so, so that obviously, we ovulate and produce eggs from the ovaries. So without our ovaries, we wouldn't, necessarily be able to have a baby. Now, for ovarian cancer treatment, like I said, most women are diagnosed with postmenopausal and ovarian cancer, but there are some women that are diagnosed very, very young. There's some, even among all ovarian cancers, there are different types of ovarian cancers depending on what type of cell they came from in the ovary. For some of those cancers, if we have a very, very young woman who still would love to have babies, we can take out the ovary that's involved by the cancer and sometimes leave the other ovary in the uterus. So there's some cancers of the ovary that we can do that for, but then there are other cancers of the ovary that behave more aggressively that our recommendation will be to remove both tubes and ovaries. However, many times we can still leave the uterus because it's really the ovaries that we're more concerned about, and if we leave the uterus in place, then women would have the option of egg donation and could use their partner's sperm to have a baby. So it kind of really sort of depends on sort of what type of ovarian cancer is found.
Yeah. Excellent. Thank you for that. Another question is about hysterectomies, and it says, do you think having a hysterectomy in addition to having your ovaries and fallopian tubes removed better protects you from getting ovarian cancer?
So I think that the thing that will most protect someone from getting ovarian cancer is removing the ovarian and the fallopian tubes. I did put on there that hysterectomy, even without removing the tubes and ovaries, can also protect a little bit, but actually simply removing the ovaries and fallopian tubes will actually decrease the risk of developing ovarian cancer by up to 90%. So I don't think hysterectomy, if you're already removing the ovaries and fallopian tubes, adds that much to that. So I think that's the most important thing. Newer research has actually interestingly shown, didn't really get into this in the talk, is that many ovarian cancers we actually think develop in the fallopian tube as opposed to the ovary. And so sometimes people have been recommending that actually if you're having your tubes tied, maybe you should just have the tubes removed, and that may decrease some of your risk of developing ovarian cancer later in life. But that's sort of a newer area, and we don't know kind of all that data, but there is kind of that thinking that definitely ovarian cancers, many of them start in the fallopian tubes, and that even if you want to keep your ovaries because you don't want to go into menopause, at least removing the fallopian tubes may help decrease your risk of developing ovarian cancer.
Okay. This question is about what you mentioned at the tail end of your presentation about PARP inhibitors. And this particular person asks, when is it that a patient would be prescribed a PARP inhibitor?
So usually we're now doing it for patients who have had upfront treatment with Taxol and carboplatin. And then when we look, either if they're BRCA 1 and 2 gene carriers, then they definitely qualify for PARP inhibitors. But we actually also look at the tumors as well, and there's certain biomarkers in the tumors that also tell us that PARP inhibitors treatment after Taxol and carboplatin may be effective, and we call that maintenance treatment. So sort of a drug that you take after upfront chemotherapy that actually you take really forever until your cancer would come back, or hopefully would never come back. I kind of think of it a little bit like hormonal therapy for breast cancer treatment, where women take tamoxifen for 5 years after their diagnosis. So it's sort of a maintenance therapy. PARP inhibitors are oral. They do have some side effects. There's some fatigue and some nausea, but not all the side effects that go with those two heavy-duty IV drugs up front. And so really for most women with ovarian cancer, the recommendation now is for PARP inhibitors afterwards. Also women whose cancer comes back, but they have a good response to Taxol and carboplatin again, we also use it in that setting too. So
Excellent. You guys are asking wonderful questions. Keep them coming. This one is about genetic testing. Says, I am BRCA positive. What steps would my daughter take to get genetic testing, and is it typically covered by insurance?
Yeah, if you are BRCA positive, and your daughter would automatically qualify for testing. And I think right now we haven't had much difficulties in folks getting tested. Right now, actually, even for our ovarian cancer patients, given how rare ovarian cancer is, we actually offer genetic testing to all ovarian cancer patients just simply because they have ovarian cancer and it's rare. So I think it should be covered. We haven't had many problems. One of the things that helps it being covered is actually the cost of the genetic testing has really come down in most recent years. So, I highly encourage her to be tested so that she can plan when she wants to have children and plan her future. Because like I said, the risk-reducing surgeries are really, really good. And so I have many, many women who are BRCA carriers in my patient population.
Yeah. This is a similar question, but it's without the BRCA gene. So this person has a strong family history of breast cancer, but they're not BRCA positive. What is their risk for ovarian cancer?
So we think the risk actually, the risk of once you have one cancer, you are at a slightly increased risk of having another cancer just by having one cancer. But we really don't think that your risk of ovarian cancer is any different than kind of the next cancer risk. And so we typically don't recommend, if the BRCA gene testing is negative, for removal of the ovaries or anything like that. There are, the genetic testing, I will say, gets updated every couple of years, and so it's always worth talking with your breast cancer doctor or your gynecologist about whether they're not their new genes that you could be tested for, because definitely every year it seems like we find more genes that aren't BRCA that are associated with increased risk of breast and ovarian cancer.
Okay. And then I think we have time for one more, and this is about things that they've seen on TV. I've seen advertisements for lawyers talking about talcum powder. What does the use of talcum powder relate to ovarian cancer? Does it increase my risk?
So that is an area of great controversy. So there are studies that have shown maybe there's an increased risk. There are studies that have not. There's a suggestion that talcum powder used a long time ago may have had a little bit of asbestos in it. There was a recent big study that just was reported that didn't think there was increased risk. It's hard because when you do those studies and ask women who have ovarian cancer or not have ovarian cancer whether they use talcum powder, it always will be a little bit of bias that if you have a cancer history, that you're going to think of those things more than if you've never had a cancer history. And so there's always a little bit of inherent bias in it. So I will have to say that I just think it's controversial. Yeah.
Okay. Well, we are, again, so thankful for your time today, Dr. Bae-Jump.
Yeah, thank you for having me.
And for all the information you shared today. We want to call your attention to next month's Cancer Conversations, where we'll have a social worker with us talking about caregiver burnout, and that'll be on March 27th from 12 to 1 p.m. So thank you so much for joining us today, and thank you again, Dr. Bae-Jump.
Yep, my pleasure.
And if you have any technical questions about the presentation you saw today, you could send those emails and we will help you. Thank you so much.
All right, thank you. Have a great weekend.